Hey everyone, I'm Dr. Mandy, founder of IC Healer, and I am here with Dr. Ryan, and he is a naturopathic doctor who specializes in chronic embedded UTIs. I know we always are talking about this. This is a really hot topic, and there's not a lot of people out there who understand this phenomenon, and he does. And so we're going to dive in. We're going to dive into a lot of different topics today, though, not just exclusive to chronic UTI. We're going to dive into mold toxicity, Lyme, just overall functional medicine, IC, of course, and then the chronic embedded UTI piece of it. So hi, Dr. Ryan.
Hi.
So glad to have you. It's always good to hear from people who have, this level of training because they're really hard to find, especially in the
Mhm.
conventional world. So it's nice that you can actually integrate that into naturopathic medicine. So I'm going to actually introduce him because I think it's really important that everyone understands what his background is. He is a doctorate in naturopathic medicine, and he, after about 4 years, medical training at the National University of Natural Medicine in Portland, Oregon. And when he graduated, he completed a very competitive and demanding postgraduate clinical residency, and he was primarily focusing on integrative primary care and preventative cardiology. But after he completed his training, he stayed in Oregon and practiced his naturopathic medicine and returned back to Indianapolis in 2021. And he opened his clinic, which is Crossroads Integrative Medicine. And now he's had a major passion in treating chronic embedded urinary tract infections with a more integrative approach, which is music to my ears, and I'm sure everyone else's ears, blending treatment modalities backed by the latest research and advancements in the world of chronic bladder pain and IC. So we are really glad to have you here today.
Yeah,
Um,
happy to be here.
Thank you. So tell me, really quickly to the audience, and you told me
Mhm.
here today, what got you into functional medicine?
Yeah, so my mother was a nurse, ICU nurse at a local hospital here in Indianapolis, and early on, just had to dive into the world of medicine, and so was a tech up in the ICU and med surg, so I got to get the nitty gritty of healthcare and emptying out bedpans and ostomy bags and all the fun stuff, and really learned kind of what patient care was. And fast forward a few years, I was up in Chicago working in an ER and down in a lab, and same kind of thing. I was a little unsatisfied with kind of the state of healthcare. Was applying for schools at the time, and had a friend of mine that actually suggested looking into naturopathic medicine, and did, and fell in love, and 4 years of school and 2 years of residency, and here I am.
Nice. Yeah, that's everyone has a story, so I'm always curious to know what people's
Hmm.
story was. So, alrighty, so we're gonna jump right in. Hot topic here, mold
Yeah.
toxicity, right? Like
Hmm.
everywhere, it's rampant. Like you meet someone and there it is. What do you think's
Hmm.
going on?
So in the world of chronic, bladder pain and embedded UTIs, interstitial cystitis, that whole world, you know, a big reason I think, that with mold toxicity, or at least what I have found, is because when testing these patients using whether it's Great Plains Lab, Vibrant, whomever, I don't get paid by anyone, but whomever to test for mold toxicities, typically the patient that is struggling with the embedded UTIs has much higher levels of mold. So, first thing I ask is, why is that? Why is one person, if they're working from home, if, the entire family's been tested, why is one person suffering more than the other? And a lot of times what I've found is because with a chronic bladder condition, especially if someone's been treated with long courses of antibiotics and their gastrointestinal tract is not functioning well, and they are feeling miserable because of course they are, they're having, they feel miserable. They have to urinate all the time. It's painful. A lot of bladder pressure, urgency, awareness is they're not sweating, and they're not exercising. And so all of those detoxification pathways that we rely on uh, aren't working now. They're not working. So the bladder's not working. The gut's not working. The sweat's not working. So where is everything going? It's staying inside. And so, you know, I find that a lot of times with mold toxicity, that our body's detoxification pathways are just not functioning that well. And sure, there are genetic aspects to it that need to be looked into. There are certain things that such as fibrin that can keep mold kind of embedded into different tissues. There are other aspects to it, but what I've found a lot of times with that chronic bladder condition is we're not able to urinate it out. It's just stuck there because we are exposed to mold everywhere. I mean, being from Oregon, mold's everywhere, right? It's damp, it's cold, mold's growing. So it's how we can actually get it out of our system is the big key.
I really like that philosophy. I actually had a meeting with Dr. Andrew Campbell with my micro lab, and he believes everyone should be on 6 months of itraconazole. What's your thoughts on that?
So again, it's with itraconazole, sure, it might be helping out with the mold, but is it fixing the issue at hand? You know, is it when you come off the itraconazole, one, you know, itraconazole has its own side effects, right? It impacts the liver. You know, it can, especially if they're on different types of medications, they can be, you know, interact poorly. You know, a lot of these antifungals have black box warnings for a reason. And so if you are not focusing again on the more integrated approach, you know, the more holistic approach of like, hey, this is addressing that mold, but you know, one of the first things with mold toxicity is one, remove, you know, get it out. And so sure, you can use itraconazole to help out with that, but I am always of the mindset that a medication is not just, it's rarely in our world, at least in functional medicine, it's rarely the one thing. You know, it usually has to be combined with other aspects. So sure, itraconazole might be effective, but how are you helping to mobilize and move those mycotoxins out?
Yeah, completely agree. And if they're living in a house that is currently actively
Mhm.
infested with mold, what do you recommend in those situations?
Yeah, that's tough. You know, there's a lot of mold remediation companies out there. Some have more credibility than others. You know, I see people really all over the place, all over the world, and so it can be hard to find a decent or reliable company, you know, in your local area, and so it can be hard. Yeah, that's just the rub of it, and it's very expensive. You know, it can be a quite pricey, not only to get tested, but then to go through the whole mold remediation process. So, and you know, I've had patients too that have had to move. You know, they've had to move out of their current living situation, and that's obviously a huge stress as well as cost to the whole family. And so it depends. You know, it depends on what someone's financial, you know, capability is. It depends on how much mold there is in the house. It depends on if it's a mold that can be cleaned using, you know, respirators and homemade products. You know, so there are alternatives. It's just identifying the mold, finding out where it's coming from, and doing your best to see if it's something that you can either get rid of on your own with proper precautions or hire a company if you have the means.
Okay, yep, I agree. So next, Lyme, another one that I remember
Mhm.
a long time ago, I went down that Lyme, I call it the rabbit chase, you know,
Right.
going down that rabbit hole. Yeah, it's just there's like so many different parts to that. Like, is
Mhm.
it really Lyme? What test did you use? Is the Western blot accurate? What other tests are? Is it
Yeah.
chronic? Does everybody have Lyme, right? Is it
Right.
opportunistic? What do you think?
Yeah. I mean, it's definitely a big mixed bag of things. Yeah, it's hard. It's a hard question to answer because I don't think that we really know truly what impact it has on our bodies. Because you have obviously one side of the spectrum where they're like, it's not an issue at all. You know, it's over diagnosed. It's really not that big of a thing. And then you have people on the other side that are saying like it's everywhere. You know, everyone's got it. It's transmissible from mom to fetus, and I think that there are some truths to both sides of that, but it's somewhere in the middle. And we're still trying to figure that out because I do agree that most testing for Lyme is garbage. You know, it's not that great, you know, especially if you are, maybe you said you were bit by a tick 10 years ago, 5 years ago, and you're running a test request, LabCorp, not saying anything bad against them. I've got, you know, run a lot of tests through them, but a lot of the standard Lyme testing is not going to pick up on something that might be a little bit more chronic. You know, Lyme, the spirochetes have life cycles, and so catching it during certain parts of the life cycle can be important. And so when you're looking at certain immunoglobulins like the IgG and IgM and trying to, you know, do the PCRs, some of these more advanced testing, such as IGeneX or Vibrant or medical diagnostics lab, those can be a little bit better to help see what potential burden the patient has with Lyme. Now, again, going back to my previous talk about mold, cost can become an issue here, right? Because Lyme testing is not cheap. And so sometimes too, what I'll do is I'll use tests such as the CD57 or HNK1 panel, or I'll run an immunoglobulin subclass panel to see if someone's immune system is more impacted than with a mold or Lyme, then it can kind of point me in that direction. Then also you have to go based on clinical symptoms too. And so, really it's trying to find, using information both clinically and laboratory findings to see what impact Lyme might have, because I've had patients that have shown up very positive on Lyme and present completely different than someone that might show up that has more typical Lyme symptoms, but they're not maybe showing up really high on their, IGeneX or whatever. So I think it has to do with someone's immune system, someone's inflammatory state. It depends on nutrition, depends on, a lot of different factors. Again, it's not just a simple answer of like, yes, you have Lyme, here's the treatment, because I've found that you hit people with, whatever medication you choose to go down, whether it's herbal or pharmaceutical, and they don't get better. And so, I've had patients where I've just worked on detox pathways for Lyme, and hey, they've, had a runner that was running, 50 miles and then had this debilitating Lyme, couldn't run. Then we worked solely on detox pathways, like told her no antimicrobials, just detox, just move things out. You just try to get that back on, get that clicking again. And she's back to running. So now we're working on helping to, tie in those antimicrobials when possible, but she's, so much better just on that alone. So was the Lyme necessarily the big thing? Was it, again, kind of working on the immune system inflammatory pathways that just keep us from functioning properly? I think it's just it's a big question that we don't have all the answers for yet. So
yeah, I agree. In fact, with my scope of practice, because nutrition is a big part of that, I
right.
look to build up people's foundation first and build up their immune system. And I find that if you go right to antimicrobials, they're going to have such a herx and they're going to fall off
Yeah.
that cliff and they're going to hate you. So that's why I like to spend a
Yeah.
few months of like, HTMA, let's get that, those minerals and those vitamins into your system. 'Cause a lot of them are so depleted and just, sometimes they're eating a lot of garbage, and just fixing that and fixing the digestive health seems to
Right.
help them in the case they do need an antimicrobial later on, they can handle it better and they're going to have less
Right.
of a side effect. So speaking of that, what role do you think nutrition plays in the complexity of autoimmune and autoinflammatory disorders?
Nothing at all. Just kidding. Of course, it plays a huge amount. Yeah, absolutely. Nutrition plays a large amount. And, and this is something that, I might differ with, the School of Clinical Nutrition, but, I find that certain diets, while they might be helpful, such as like the autoimmune paleo, for example, it can be very helpful for when someone's in a very acute state. But it's also very limiting, right? And so with nutrition, you want to get good diversity of different types of foods. And some of these, and that's why too, I think having someone that has, and this might be, speaking more from someone, that is going off like, oh, I see this autoimmune diet, I'm just going to follow it for the next 6 years without consulting anyone, right? And so it's more, you need to find someone that knows what they're doing that can help to guide you through that, because sure, it might really help you in that time, but is it something that's sustainable for long term? That's up to, your clinical team. That's also up to you, your how you process certain foods, because like a ketogenic diet might work well for me, but it might not work at all for you, and vice versa. And so I think that nutrition plays a gigantic role in a lot of these conditions, a lot of chronic conditions, and especially with our standard American diet, you're seeing, chronic disease on the rise, and it's not getting any better. And so, we have done a terrible job at putting nutrition on the forefront. We're just more focused on herb supplements, pharmaceuticals, instead of, really, again, focus on basics. And so I think that always is a big part to play in chronic disease and autoimmunity and inflammation. So yeah, I do. I think it's a big part.
Yeah, of course. And I look at their children and what they're eating. It
Right.
starts there, right? I mean, you go to an elementary school during a birthday party. It's horrific.
Hmm. Hmm.
So I agree. And I think yeah, I mean, it's not being given the recognition that it should. And it's aggravating sometimes as a clinical nutritionist, because we know how powerful it is, but I don't think
Hmm.
it reached that point where I think everyone understands that. And I think it's what the hard part is. I agree with you, the diversity. And so, I've done a lot of talks with like Heer with Microbiome Labs. I know him really well. And I love his philosophy on diversing the microbiome. I do believe in the rainbow diet. So I do push that one, because
Hmm.
I feel like people they're walking by things in the grocery store just because they don't know what it is. And it's like, that's the
Right.
thing you should be eating, because your microbiome needs that. That's how you build diversity. It's the only tool we have to build up our microbiome is the diet. The
Hmm.
probiotics, we're still up for debate if they're doing anything,
Hmm.
Whereas like the diet, we know that the microbes feed on that. I've seen night and day differences in microbiomes before and after just from diversifying the diet. So yeah, I completely agree with that. I think that's part of the problem with the elimination diet. I think people become really restrictive. And I don't like to call it the elimination diet. I like to call it the inclusion diet, because you're going to include
Hmm.
things that you probably wouldn't have eaten before. So, all right. So now let's dive into interstitial cystitis. In your opinion, what do you think are the most common root causes that you've seen clinically? That's a big question, I know.
Yeah. Well, there is a lot of discussion about how the bacteria itself can become embedded into the bladder wall. So, that's a part of it. Bacteria also have certain biofilms on the outside. Some are stronger than others. Like Pseudomonas is pretty strong biofilm. It makes it hard to treat, and so then thereby kind of contributes more into those embedded infections. I think that there's an inflammatory process too that is something that we have to take into consideration, whether it's high levels of histamine due to chronic infection somewhere else, oxalates, um, Lyme. I think there's also a hormonal piece that oftentimes gets overlooked. There's a reason why when women get into peri and postmenopause, they start to see a rise in different infections, whether they're standard UTIs, whether they're candida yeast infections, whether they're bacterial vaginosis. That layer of the vaginal tract and as well as the bladder, loses some of its lining with loss of estrogen. So, there's a reason why there's evidence behind, providing some topical estrogen, and that can help for some, not with everyone. I think there's a gastrointestinal connection too. And so again, when we're talking about diversity of microbes and how certain things such as small intestinal bacterial overgrowth, chronic antibiotic use, whether due to upper respiratory infections or ear infections or whatever. There's a genetic piece too, and so if someone has maybe a what's called a CBS mutation or a PI1 mutation, and their ability to process certain things or break down certain things are going to be not functional. So there's several things that might lead to that. And I'm sure the immune system. There's a few studies right now that are talking about how chronic interstitial cystitis, this umbrella term, I feel like oftentimes for a lot of these conditions, how the immune system and autoimmunity might play a part into it as well. And so the more that we understand it and the more that we study it, I think the more questions that we'll have answered. But I found with patients that everyone, for the most part, pretty much every one of my patients, there is more than just one thing. There's more than just, hey, this is an embedded infection, give an antibiotic, give a biofilm disruptor, and there you go. I haven't found that to be oftentimes the solve for really anyone. It's usually like, all right, let's look at hormone health. Okay, let's look at your inflammatory. Let's look at your diet. Let's look at your GI health. Let's look at your immune system. And so there's different parts of it that you have to take into consideration. And I've talked to other providers, Ruth Chris being one of them, but like, is it, chicken egg kind of scenario? Like, well, is the chronic infection leading to an overproduction of mast cells and therefore histamine? Is it the gastrointestinal infection that's leading to the chronic bladder infection? It's hard to know, but we know that both are problems. So again, trying to build that pillars of the foundations of your treatment by fixing nutrition, helping out with exercise, making sure that lifestyle is good, making sure stress levels are well maintained, and then working your way up that pyramid into more aggressive therapies. Like once the person's a little bit more supported, is I found to be the more successful way to approach this. So sorry, I went on a little bit of a
No,
tangent,
no, no,
but
no. I
kind of
want
answered
to
your
unpack
question.
that just a little bit more
Yeah.
with the well, I did find one very important finding because I do run nutrigenomic testing.
Mhm.
67% of my patients up until now, and I've only been checking this for 2 years because I just started documenting it, have the keep one upregulation with NRF2. 67%. That's very, very high. So I think there's something going on with that antioxidant because that antioxidant is involved in the UTI in the bladder to help. It helps with not only expulging the bacteria out of the bladder, but also helps protect the bladder lining when there is a UTI, especially when it's E. coli. So
Yeah.
that was interesting. But I want to go to the PAI one because that one is relatively new to me. I just started, running the hypercoagulation panel. I have it myself. I have the 5G, 4G deletion. Woohoo!
Right.
So yay for blood clots. But no, truthfully speaking, 50% of the population has it.
Right.
So statistically, if you look at the population of that mutation worldwide genome, right, it's 50%. So if that was it, then 50% of the population would have chronic embedded UTI. So obviously, no, that's not the case.
Right.
So there's an association, we know, with that whole, hypercoagulation and inflammation, the driver of that. So if you go upstream, it's inflammation that's driving that process. However, going back to estrogen, if somebody has a hormonal problem and that's contributing to their IC and their postmenopausal and they need estrogen, but then estrogen drives up hypercoagulation, how do you work around that? Have you thought about that?
Yeah.
That's a complicated one.
Yeah, it is. And so when they're doing, I think making differentiations too between topical vaginal estrogen and bioidentical hormone replacement therapy, whether it's pellets, patches, creams, because that's very different, right? A vaginal estrogen might not be absorbed as much. There is some absorption, of course, but it's not nearly at the level that we are seeing with some of the other therapies that you need to add. And progesterone, for example, if you've got uterus and ovaries. Progesterone is also really helpful for people that don't, that can help to balance out those high levels of estrogen. And again, due to people's genetics, they might be converting that, DHEA to testosterone, then to estrone, which is more inflammatory compared to estriol or estradiol. So, I think that it's definitely a complicated question and something that has to be, evaluated and also, kind of counsel patients through, because for now, vaginal estrogen, topical vaginal estrogen has not shown to increase the risk of endometrial or ovarian cancers. That's for right now. And we'll continue to study it. We'll continue to look at it. And that's something I tell patients. It's like, we don't know, for the longest time, they gave estrone to people and be like, I don't know why people are getting ovarian cancer. I don't know why people are getting endometrial cancer. And that's because they're just giving unimpeded estrogen. It's causing clots. It was causing issues. So it has to be talked about again with a provider and talking about like, what's my risk? What do I have that I might convert things into the wrong forms of estrogen, or I might need to have a progesterone to help protect me against blood clots. What's my inflammatory burden? What's my cardiovascular risk factor? Do I have certain things such as like lipoprotein A or high levels of low density lipoprotein that are causing inflammation to the arterioles? Are there certain things that I possess that make it more risky than others? Because some people have high LDL and perfectly fine. Some people have high LDL and are not. And I think that a lot of it has to do with how your body presents it, how the inflammatory pathway is, what's the underlying nutrition, what's the underlying health. There's a lot of things that go into it. It's not simple. So.
Okay, and so I love prevention. So now that we have all of this information, if somebody knows that they have a PAI, 4G, 5G, or if it's 4G, 4G, which is the deleterious one, right? The 4G, 4G, 5G, 5G is normal.
Correct.
Okay.
5G, 5G is normal, yeah.
Okay. So let's say you have 4G, 4G, or 4G, 5G, and you're planning a pregnancy. and
Mhm.
you're concerned that you might have that higher risk of getting UTIs or blood clots, things like that. Is there something somebody can do naturally that you know of that can prevent the potential? Because I know I personally got my urinary tract started after the infection started after I had the birth of my first daughter. Now, whether it was introduced by the catheter that they put
Mhm.
when I had the C-section, I don't know, but I know a lot of my symptoms started within a couple of years after I gave birth to her. So maybe there was something going on with estrogen hypercoagulation I didn't know about. But if somebody knows, is there anything that can be done? Do you know?
Yeah. So disclaimer, everyone should always talk to their doctor
Yeah,
before
yeah, yeah.
doing
Of
this. Yeah,
course.
yeah. Um, you know, with a 4G, say for example, PAI, which is the plasminogen activator inhibitor, with that specific gene, you are at more risk for miscarriages, you are at risk for more UTIs, just because pregnancy already is a hypercoagulated state, and the placenta is trying to adhere to the uterine wall, and there can be things genetically that your body's trying to keep that from happening. And so someone that is say 4G has that increased risk, and they're seeing certain fibrinogen fragments, or there's certain aspects of their health that are pointing more towards being hypercoagulated, then they can do things such as lumbrokinase. It's earthworm casings. It's kind of gross, but it's a natural kind of fibrinolytic. Again, it's something that should be counseled with the OB/GYN team too, because they're going to want to know about, hey, are you on any type of things that help to break apart fibrin? If it's at a point where it's too high, then and they need to talk about certain medications such as like Lovenox, then they have to have someone on board that help out manage that and help to measure certain markers of their blood. So there are things to help people with that gene as they enter into pregnancy. And again, some people are able to test for the PI1 gene beforehand. Some people's insurance will cover it, some people won't. And so making sure that you're doing the due diligence of testing when you can for the hypercoagulation panel, I think is really helpful. At least it has been for my patients. The more and more I get into practice of being like, hey, I should be checking this more often than not, because there's a lot of people that just don't know.
I
And
agree. I think if someone's trying to
yeah.
conceive, especially knowing how prevalent it is. Now the
Mhm.
4G not as much, but the 4G, 5G, and 50% of the population has that
Right.
polymorphism, then why not? Just like I think even like standard care with like OBGYN, they should just before you're trying to conceive, like let's just check because we could
Yeah.
prevent a problem. And so that's this prevention to me is so important. I just feel like people do not respect and understand how important prevention is. It's everything, really. Okay, so the embedded infections. What is your thought
Mhm.
on are you familiar with Dr. Malone in the UK?
I am. Yeah.
He had a really interesting theory behind how it all happens. What are your thoughts on his theories on how the embedded
I don't
infections?
know his theory well enough, so you might have to tell me about his theory,
Oh,
but I know
oh,
of him.
yeah, I
So,
mean, he basically says that it's basically he doesn't talk about leaky gut or anything. He just says it's the initial infection becomes embedded and becomes a biofilm, and then the urothelium actually thickens over time. And that's where we say the bladder capacity wall has actually, when they say they do the bladder capacity test and they say that your bladder capacity is shrunk, it's not that your bladder is actually shrunk, it's that the urothelium is actually thickened because of a defense mechanism because of the
mm,
infection. But what I thought was interesting with his theory was that the immune system is shielded because it's in a biofilm, but every once in a while, the body recognizes that there's a problem. And so it sheds the lining of the bladder. And when it sheds it, that's when these people are having these acute UTIs. Because sometimes people have these UTIs and everyone always blames it on intercourse, which is a whole nother topic of conversation. Why is it
mhm.
intercourse? Everyone always blames it on intercourse, but it makes me wonder if these random flare-ups that women have, that they're getting an acute UTI out of nowhere, and they're like, I swear I didn't have any intercourse. That didn't trigger it. Could that be the body's literally shedding the layer of the bacteria, the layer of the epithelium, and these embedded infections are being released and causing a UTI?
So, about a month and a half ago, or about a month ago, Professor Jenny Rowan, ROHN, she's out of the UK as well, I think, but she did a talk about that. And her team have been able to um, do essentially these ultrasounds of people's bladders and see that the bacteria will create these little pockets of infection and inflammation into the bladder wall, which, inflammation thickens anything, right? And so it's going to thicken that bladder wall too. So I think Dr. Malone has, definitely a lot of truth to his theory. And I think there is something to that, because as that bacteria embeds itself into that wall, it can, it will release and cause those flares that we hear about, and especially when, I feel like a lot of times too, when I'm starting people on, say, biofilm disruptors or lumbarokinase, trying to break apart that fibrin, people will tell me like, oh my gosh, my pee looks like a snow globe, or I'm getting all this shedding. It's like, why else would that happen? These are things that are trying to help clear out the infection. So if you think of it a little bit more logistically, of like, all right, well, if these things are doing what they're supposed to do, and I'm getting all this shedding, this lining coming out in their urine, I think that's the bladder essentially trying to push it out. And people, of course, go back to like how you're able to detox, how are you able to get things out, making sure people are staying well hydrated. If it's predominantly like a gram-negative bacteria, maybe they should be on D-mannose. If it's more gram-positive, like enterococcus, you might want to focus more on helping out with the CBS mutation and ammonia levels and help out with L-ornithine. That's when sometimes people need antibiotics. Sometimes people can do well on antimicrobial herbs. Everyone's going to be a little bit different with tolerance and also how much the bacteria is there. So yeah, I think that there is a lot of truth to that. And I think, if anyone wants to get a little bit more, or like a visual graphic, Professor Jenny Rohn just had a recent talk on like why we should be angry about UTIs, I think is the name. But it was
Where
really
would we
helpful.
find that talk?
YouTube. It's just,
Okay.
yeah,
She
it's
has a graphic. Okay, that's really
yeah,
cool.
and she had this talk about it's why we should be angry about UTIs. I think it was the name of it. And she had her and her team, you could see like those pockets of bacteria, which is fascinating.
So if it's pockets of bacteria in the epithelium, is it pretty safe to say that the functionality of the epithelium has become dysfunctional, like the gut does? Could there be possibly, because there's been underlying inflammation? We know that cathelicidin is also really important, right? Cathelicidin, because it's a protein
Mhm.
that's involved, vitamin D dependent protein that helps with
Mhm.
these UTIs. So maybe there's a lot of I guess I want to say, I always use the analogy that babies sit in diapers all day long and they don't get UTIs, even though these girls are sitting in a diaper and their urethra is smothered with poop.
Mhm.
Why don't they get UTIs, but then adults are? So something's happening to the lining of the bladder. Is it safe to say that there's a problem there?
Yeah, and I think again it goes back to what I was talking about, how it's multifactorial. It's not just bacteria is being introduced, because you're right. I've got a 1.5-year-old daughter. I know that, and very much today she's like, "Oh, you pooped," and "Oh, it's caked on there," and "Oh, it's probably been there for a while." But
You must be
it's happened
horrified as a
before.
UTI expert when
All
you
right,
see that.
I know, and it is definitely crossed my mind, being like,
Claim it,
"Oh my
claim
gosh, here we go." But
it.
she's done that several times, and yes, she has not had a urinary tract infection,
Right.
and so and there are people that due to a disability or something that will have bowel movements and not get UTIs. Maybe they might be a little bit more susceptible than others, but there is something that goes on later on in life that is either tied to the immune system, tied to inflammation, tied to gastrointestinal, tied to genetics. There's something that we have to kind of work through to figure out why that might be, because you know pregnancy, bring that up about how people post pregnancy will see this kind of come on. And so what happens in pregnancy? Like, yes, catheterization is one part. So is the bacteria being introduced to the epithelium? That could be a potential. Hormones fluctuate like crazy. There's a big drop, and women have to accommodate for that drop, and sometimes that can put people into, like, if someone's more susceptible to a infection, that might make someone more susceptible to it. Also, you see, like, in certain autoimmune conditions such as Hashimoto's, like Hashimoto's for some people goes into remission during pregnancy, and then when they come out of pregnancy is when it flares back up again. So why is that? So obviously there's immune system involvement too. Immune system is fluctuating from having, oh, I have this this parasite inside of me, I need to support, I can't be like a causing all of this immune markers to go and try to attack the fetus. I need to protect that. But when all that's gone, it shifts, right? The immune system will shift. And so that has a part to play into it too. So yes, I think that the bladder epithelium and dysfunction is one aspect to it, but again, there's other parts that play into it.
Yeah, and how about the E. coli getting more
Yeah.
virulence? Do you think there are E. coli from our food industry could be getting more? I was reading these studies about like poultry and pork and being the primary foodborne UTI culprits from the food industry. So do you think that the bacteria that's in our food has also changed and gotten more virulent, like more dangerous to us? You know what I mean?
Yeah. So what was it? I think maybe 2 years ago or a year ago that there was a report, was that the FDA or some big governmental organization that talked about how people that consumed higher levels of red meat that weren't sourced properly. So say it was like a cow from a farm that fed their cows antibiotics and you highly pesticide filled food, that they were more susceptible to E. coli infections. So obviously that talked about the connection between the gut and the bladder, right? Well, think too about what those animals are being fed, and oftentimes they are being fed antibiotics. So if an E. coli, for example, that is being fed with the same antibiotics over and over and over again, it's going to be more resistant to those antibiotics because bacteria is smart. It develops resistance. It develops certain genes that help it evade antibiotics. And so when it gets introduced to humans, we have those same kind of antibiotics. And so when they're given, say, nitrofurantoin or amoxicillin clavinic acid or trimethoprim sulfamethoxazole, like say they're given the standard UTI treatments, Augmentin's not really standard, but say they're giving those and they're showing up resistant. Well, I think a lot of that's having to do with, where's that E. coli coming from? What type of antibiotics are we giving ourselves and our food? Which is why I understand that antibiotics sometimes are necessary, but they can't just be used willy-nilly or used irresponsibly. They have to be, have to get sensitivities and resistances on the antibiotics, on the bacteria itself to see what antibiotics there are. And also, if you can avoid using antibiotics and using other ways to help kill off bacteria, whether it's through natural approaches, whether it's through nutrition, whether it's helping to manage inflammation, then doing that instead of jumping into, all right, here's another course of Augmentin, here's another course of Doxy, here's another
I
course of
agree. I'm so
Macrobit.
glad you said that because
Yeah.
that's where I'm struggling with because, I know that when we, run microgen and it's immediately the first thing that's being recommended. And I'm like, some people, they're coming to me, they don't want more antibiotics. They're done. They're like, I'm
Right.
coming to you because I don't want any more antibiotics. And that's, I'm glad that you said that. So last question for you then, in your practice, how do you tackle embedded infections, or is it a case-by-case situation depending on the patient?
Yeah, it's totally case by case. And so everyone's going to be a little bit unique. There are obviously a lot of similarities. It's usually like, hey, I had this really bad UTI, whether it was after, pregnancy, whether it was after intercourse with a new partner, whether it was after, having an extreme stressful event, whether it was after acute illness. There's usually a predicating event, and then starts this pattern to happen. And so then the strong UTI leads then to, okay, it was treated, got a little bit better, and it's come back again, and came back again. It's more frequent. That's more frequent. Now it's happening all the time. And so that oftentimes happens, for the patients that I see, and usually they go through the gambit of like, I saw my primary care, they gave me an antibiotic, then they stopped giving me antibiotics, then went to the ER, or they went to a urologist, or they went to infectious disease. And again, it's like, they just say that everything's fine. Cultures are coming back fine. They gave me antidepressants, they gave me, pain medication, and it's usually the same story over and over and over again. So that part, the history is pretty similar for most people. But how I deal with the embedded infection or how I deal with the chronic UTIs or IC is going to be completely unique to the individual because is it more genetically focused, is it more immune focused, is it more inflammatory focused? It just depends. And so I've found that everyone has to be approached differently. And so yeah, to answer your question.
Is there a harm if someone has a pretty complex embedded UTI and they don't want to take an antibiotic, would it hurt them to try naturally for a few months? I mean, I guess the concern we have is it going to get worse and damage
Worse.
the bladder
Yeah.
more? What are your thoughts on that?
Yeah. And that's a quandary that I have myself, because as someone that lives in the world of both, both pharmaceutical and herbal approaches, it is a concern that, hey, if I don't treat this bacteria, will it become worse? And so that's why with the way that I practice is mostly like, all right, we're going to do this herbal protocol, but we're going to recheck in about 3 or 4 weeks. If the bacteria is still there, if it's growing, if your symptoms are not getting any better, then we need to talk about either doing more aggressive therapy, or we need to seriously consider using an antibiotic. And of course, there's different ways to administer that, right? There's oral, there's IV, there's intravesical, so like bladder installations. And so we'll walk through the patient, through that. And again, context matters, right? And so patient symptoms, patient's immune system status, patient's inflammatory status, patient's, other risk factors that contribute into that
Age,
conversation of age. Yep.
age, yeah,
Yep.
age. I find age. That's what I found with the age. Because
Yeah.
my younger patients who are like under, I would say under 45, 50, I've had some really good success without having
Yeah.
anyone to get an antibiotic, and their UTIs just went away. But once they're postmenopausal, that's where I found the challenge.
Yeah. And so then again, that ties into why, why is that the case? Like, is the estrogen completely thinning out that layer? So the good bacteria that we should have in our urobiome and our vaginal biome is not, there. And so, I've found success with like giving, again, when it's indicated, vaginal estrogen and vaginal probiotics. Or, there's been some recent studying, and we're still kind of figuring this out too, of instilling probiotics into the bladder, instilling lactobacillus rhamnosus or lactobacillus reuteri, things that we've found to be more foundational for the vaginal and urinary microbiomes, to help build, to help, repopulate. Because, yes, are probiotics the everything? No, they're not. But can they be helpful in certain situations? They can. So that's
And maybe
to
even
be
short term too, because
discovered.
to
Right.
get the infection
Yeah,
under
it's not a
control.
long term, it's not
Right.
definitely like do this for the rest of your life. It's usually a short term course. Let's see if we can kind of overcrowd and repopulate, with some good bacteria, and then prevent the flares, preventing, reinfections, preventing inflammation. Yeah.
That's wonderful. So it was really good to speak to you today. This was a lot of really good information. So anything else you want to share first before we end this?
Not really. I mean, really, this is a constantly growing and evolving world as far as treatment goes. I continue to try to learn and meet new people that have been treating this either longer than I've been alive for some people, or people that longer have been in practice. And I'm a fairly new doctor, and I know that. I've only been in practice for, so graduated in 19. So what is that? 5 years. And so I'm fairly green in this, but at the same time, I think I've learned a lot, and learned a lot about the body, and learned about a world I didn't really anticipate getting into. And so, I think for people listening to this, there are people out there, and we're recruiting people to come, learn more about this. And if you are a provider, hey, I might need some help here pretty soon to help out with patient loads, because, my practice, the way that I build it, is a membership based, but people can still see me, pay per visit. And so, but I obviously only have a certain amount of hours in a day and a certain amount of patients I can take on. So it is one of those things that I am a little anxious in trying to bring on more people so we can support a bigger population of patients, because, it's, I'm getting close to being at my max. So help.
Oh yeah, sure. Yeah. I mean that we can always utilize these
Yeah.
others, services for sure. And I'm really
Mhm.
glad to I know that I have, somebody I can refer people to now.
Right.
No, that's good. So I'm also relatively new too. So I probably graduated around the same time you did. The
Mhm.
second career for me. So, and it is a big world. What we need to do is create our own IC conference, because I don't like the other IC conference.
I know.
the conventional one. I'm not a fan of that one. We got to create an integrative IC conference, right? Like that's like the
Yeah,
one of
well,
my
there's starting to be
vision.
enough of us that it
Yeah,
really could be a thing, and that's definitely been something that's on my mind over the past year and a half. And the more and more people that you meet, the more ability for us to learn from each other, because that's a big thing too. Is I learned so much from other providers
Mhm.
about like, hey, have you tried this? Or hey, I've been doing this and this has been working out well. Because again, we're limited in what we can do. And
Yeah.
unfortunately in my practice, I see a lot of people virtually, I see some people locally, but I don't work with another provider that is specialized in IC or chronic UTIs. I work and communicate with people like yourself and others, through Zoom when I can.
Yeah.
And so it can be
Same
tough.
here.
But
No, it's great. I mean, I'll talk to Ruth about that. See if we can kind of get that going, because that'd be nice to have
yeah.
an annual meet and greet. So
Yeah, and get
thank you so
Cirrus
much.
and Microgen and all these companies that we're giving all the money, get them to fund it, right? If you're listening to
100%. I'm sure they would. Why
no,
wouldn't
I know they
they?
would, because I mean, we're their patient population, or we're their
Exactly. I
population.
will definitely, and ophthalmologist Rochelle
Hmm.
Stern,
Hmm.
I know her really well.
I've talked to her. I've talked to her.
Yeah,
Yeah.
yeah. I want to touch base with her. She might be willing to to help put this together. This could be really interesting. Yeah. So how can people find you?
So people can find me online. So
Okay,
crossroadsintegrative.com.
perfect.
If people search Crossroads Integrative Medicine or my name, Ryan, Heer, it's Heer, that's how
Yeah.
it's pronounced. It doesn't look
Okay.
like it's hair, but it is. I am not great at social media, so if you communicate with me over that, I'm sorry, I probably will not respond.
Okay, I
Um,
gotcha.
yeah, and then so people just do the website. It's usually the best way. I
Okay.
get a lot of referrals from either other patients or Ruth, sends me people. I think I'm also on the IC network. I don't know.
Okay.
And then people find me also through like certain Facebook forums and stuff.
Have
But
you interviewed
yeah,
in Live UTI yet?
I maybe have.
Okay.
Sorry, I've interviewed with a decent, and I know of them, and I know that I've gotten people from them, so they must have my information somehow.
Okay.
So I
Okay.
probably
Yeah,
did.
yeah. I was like, you need to be on there. All right. Well,
Yeah,
good. It's good to meet you, and we will be in touch for
me too.
sure. And yeah, hopefully we'll get that conference going.
Sounds good.
Thank you so much.
You betcha.
Bye bye.